Hello?
Good morning, Mona. I'm audible. Hello. Mona, am I audible? You were able to hear me? Hello.
Hello.
Mona, I can able to hear you. You are able to hear me?
Sir, sorry, sir. Now I'm able to hear you. Sorry, sir. Good morning.
Good morning, Mona. We'll start.
Yes, sir.
Okay. We'll
Yes.
share the screen. You able to see the screen?
Hello.
You're able to see the screen now?
Yes, sir.
Okay. So yesterday we were discussing on the first section in the ICD
Yes, sir.
that we were discussing on the convention. So just to let me give you a small brush up on that so that we can
Yes.
continue with the second guidelines. Okay. So among these entire guidelines, this first section is very, very important. Okay. So
Yes,
it's
sir.
like not only now, like even for coding and all the aspects, that will be
Yes.
useful.
Yes. So one small doubt.
Yes.
Am I able to record the screen now?
I don't think so. You'll not be able to record the screen.
Okay, so you just record and send it me, no?
Yeah, I already sent you. I think.
Yesterday's one, yeah, I got.
Okay,
Today's one.
you will
Yes.
get it in a drive because the size will be bigger one. Okay.
Yes.
So,
Okay.
yes, even yesterday, what happened? Like I spoke to you in the end, I was not able to. I missed to stop the recording.
Okay, okay.
Then I requested to the Google person because we are having the workspace, Google workspace.
Okay, sir.
Requested somehow they took me and gave me actually.
Sir. If
Uh,
I'm not able to record the screen, no, so you
that,
just
that
record it
option
and
will not
send
be
me
there.
the daily update.
You will be the host, right? That option will not be there. Okay.
Sir.
Uh,
Okay, sir. Today's class also, you just record and send it me.
yeah. You will get it. The record is already started. Okay. So I will share you the link. You can see in the link whenever you.
Okay, sir. Okay, sir. Thanks.
So yesterday, like to brush up on the yesterday's section, the conventions. So discussing on the format and structures. I hope you remember the format and structures, category and subcategory, and the
Yes, sir.
qualifiers and the
Yes.
placeholder. Wherever the seventh character is not filling in between, we can use the placeholders which indicate in the X alphabet. Then seventh character to indicate whether they what type of encounter, and especially it is seen in chapter 13, chapter 15, and chapter 19. In some of the chapters, 7 as well. Then we were discussing on what is the difference between alphabetic index and tabular list. Alphabet, it will index, it will provide you the by the main term you are going to take the diagnosis from there, whatever the guidelines and whatever the inclusions and exclusions or use additional codes or code also, whatever the guidelines need to be, that need to be checked in the tabular list. There is a big difference. Then we are seeing in the punctuations and so these two are like it will provide an additional information, a combination information for the any conditions or any sentence or phrase we are seeing in the tabular list. Then other specified, unspecified, other specified, which is like physician is given the name of the condition, but that condition is not documented in the, so not listed in the ICD book.
ICD book.
Whereas unspecified, physician is not providing the condition, specific condition, like they are not mentioning the condition name properly. That will become the unspecified. We call it as
Unspecified.
NEC and NOS. NEC
NOS.
will be like not elsewhere classified, whereas NOS is not otherwise specified.
Specified.
Then include notes and include terms, which will give you the additional information on the ICD. Include terms, it will tell you like what are the other terms are included, where include notes will provide additional information about that particular ICD as well as the condition. Exclude one, we do not code a combined code. Exclude two, yes, it can be coded if the documentation is supported. Then etiology
Yes.
and manifestation, a primary condition is etiology. Because of the primary condition, when the secondary defect is coming, that we call it as a manifestation, where you will be having the guidelines of use additional code or code first, guidelines in this particular section. Then with and those are like it will be leading you the code and it will be combining the code like a contact by, due to. So these are the prepositions which will be used to indicate the diagnosis. Then default codes and shared codes, which is like a shared nodes, which will indicate shared lines, which will indicate how to see the ICD. And default codes, like what are the codes leading directly, that codes need to be considered. Okay, these are the some of the things we have seen yesterday. That's a quick refresh on the conventions yesterday. Today we'll
Yeah.
start the second one. In the section one, we have the B. The B will be discussing on the general coding guidelines. Okay, so this general coding guidelines, it will be like for both the inpatient and as well as the outpatient. Most it will be focusing on the outpatient. So simultaneously we'll be discussing on the both. Okay, so first thing is what you are seeing, it will tell you like the general guidelines. The first point is like locating the code in ICD 10 CM. So this is something we have seen in the beginning itself, right? So
Yes,
how
sir.
to locate the code? Go to the index page with the main term. You will get in for three decimals to four decimals of character. For the fourth character, fifth character, seventh character, you have to go and check in the tabular list.
Tabular list.
So that is a two set of process. Will be two stages of process will be used in the leading the code. Then leveling and leveling of a detailing code. So here, what they're trying to tell is like we have to code the highest level of the code, which means like when you get unspecified, other specified, and specific code, specified followed by other specified, then it is followed by the unspecified code. So that will be the hierarchy. Okay. The next one is like what you are seeing on is sorry, code or codes from A through T, Z, and U. Nothing. So whatever the diagnosis condition you are going to get, please follow the 22 chapters guidelines and take the codes from the 22 chapters. That is what we're trying to tell in the B3 section of the general coding guidelines. Next is the signs and symptom. So in the signs and symptom, so what is sign and what is symptom? Sign something I can able to see with my naked eyes. Symptom something which I need to tell to the physician. That is a big difference. So in short, we call it as sign will be subjective. The subject, I am the subject. I should tell, sir, I am having the bleeding. Okay, sorry. The subjective means the physician able to see that, and same time you will be also able to see that. Okay, so that will become the sign will become the objective. So when it comes for the symptom, it will become the subjective. So I'll be the subjective, which means like I have to tell by opening my mouth. So if I have some pain inside to me, unless or until that subject is telling to somebody, you will not be able to understand that. You will not be able to go for the further diagnosis. So that is a big difference between the symptom and sign. So sign is something you can be able to see with your naked eyes. Symptom is something you should be telling with your mouth. Okay, that is a major difference. Then condition that are integral part of the disease. So next is like condition that are integral part of the disease, and one more is like condition that are not an integral part of the disease. Okay, so what is the integral part of the disease? It's nothing. Say for example, I provided one example here: pneumonia with fever, and one more is a diabetes with elevated uh, glucose or
Glucose
polyuria.
urination.
So when I get a pneumonia, I get the infiltration, consolidation, fever, cough, SOB, dyspnea. Okay, so these all are the signs and symptoms which are the indicators for the pneumonia. Okay, so any lung related or any respiratory related conditions, with that, if you have any respiratory related signs and symptoms, I need to focus and code only the proven condition. It is not mandatorily or necessarily to be coded as the other signs or symptoms. So that is the guidelines. What the guideline says is like when the patient is coming with signs and symptoms, if condition is proved, you have to go to the condition only. But
Yes.
due to some projects like a project requirement and ICD cover requirement and billing purpose, we do some adjustments. Okay, so some places they want at least 4 ICDs. So they ask us to code the signs and symptoms also. Even in the traumatic report, we used to code degeneration, non-traumatic conditions also, they may ask us to code. Depending on the client specification, that may vary. But what the guideline says, ICD guideline says is like it should be proved. And if the signs and symptoms are related to that condition, I cannot code that signs and symptom as a secondary code or tertiary code or the fourth code. Okay, that is what a main concept here. So two examples, if you see the second one, if you see diabetes, elevated blood glucose, polyurination, these are the symptoms of the diabetes. Again, I don't want to code the elevated blood glucose or polyurination. That is what they're trying to tell you. If you see the next one, not an integral part of the disease. It is you may have the unrelated signs and symptoms. Okay, if you see urinary tract infection, right? Urinary tract
Yes.
infection is related to the gastrointestinal, sorry, genitourinary system. Whereas dyspnea is for related to the respiratory system. So both are different systems. Now,
Yes,
the
sir.
condition is proved. What the condition is proved? That we are going to take urinary tract infection. That is a condition we are going to consider as per the documentation. Okay, if you see,
Yes.
patient admitted with the cystitis and dyspnea. Now, when it
Mm.
is for urinary tract infection, I code urinary tract infection. Followed by that, I can code the shortness of breath, which is not completely related to the urinary tract infection. So this is different system, that is different system. In that situation, I can code the both. That is what they're trying to tell, not an integral part of the disease. Okay. So next one is a multiple coding. Okay. Here, when they talk about the multiple coding, it's nothing like we came across the conventions, right? Code
Yes.
addition or code also. Okay, that is what a multiple coding. So you may have one condition, but that condition will make you to code two ICDs. Okay, that is what multiple coding. So you may encounter three ICDs also. Sometime we may able to code, especially if you see the sepsis along with the sepsis, severe sepsis, organ failure. If you see one problem like one condition, especially on the sepsis, you have to code what type of sepsis it is, what type of infection it is, and you should be coding what is the organ failure as well. So septic shock and severe sepsis, usually it will come with the three different ICDs where condition will be only one. Okay, that is what they're trying to tell. Multiple coding for a single condition. The next part is like acute and chronic conditions. Okay, now how I'm going to differentiate acute and chronic conditions? Quite interesting. Always there will be a problem. The outpatient situations when you see, like we are like old school. So in our generation, we clearly understand what is a chronic condition, what is acute condition. If you see the people after 2015 and 16 and all, they are not able to differentiate. So there is a guideline says that do not code the chronic condition. It doesn't mean you shouldn't be coding all the chronic condition. There are the condition where you should be coding chronic. See, chronic fracture, that is a fracture is already healed. I don't want to again repeat that fracture because what the codes I have is like all the codes are related to the current condition only. When you take for fracture codes, all those comes in the chapter 19. S series, right? S series means acute. All are currently happened. So current traumatic, current injury codes, those you will be able to see in the chapter 19. But when the documentation is told chronic fracture, coders may confuse like, okay, fracture need to be considered. And there is a places where chronic pancreatitis, chronic thrombosis, these are all the conditions where people may think like these are the chronic conditions you shouldn't be coding. No, chronic pancreatitis is a long-term process where from the acute to subacute pancreatitis, from there the chronic will be developed. When you become a chronic patient, you may not have the adverse effect which you had through the acute pancreatitis or subacute pancreatitis, but during the chronic you may encounter small effects, maybe digestion problem, or sometimes you may have the thirst problem, or you may have the sometimes secretion of insulin also you may get problem. That is the reason we call it as chronic pancreatitis. Then when you say chronic thrombosis, chronic thrombosis, why I'm telling thrombosis is something not it will start yesterday and it will develop today itself. Chronic thrombosis means the development of thrombosis, right? The embolism and thrombosis. So thrombosis is something which will be stagnantly attached. That is like some clot is attached or plague is attached in a particular vascular structure, which is especially in the arteries. Embolism is something it will travel from one place to other place. That is also kind of clot or some kind of plague which will be formed in the vascular structure. Now, when they tell chronic thrombosis, people may think like chronic means it is there for long time. Why should be coding? No. First month it will be 10 percentage. Third month it will be 30 percentage. Fourth month it will be 50 percentage. And 1 year it will become 90 percentage of blockage. In that situation, that is a chronic only. But what is the misconception here? People may think like, okay, chronic means it is very long. I shouldn't be coding because guidelines says that. No, it's not like that. Not all the conditions are applied like that. But we have the generally spoken points. What is acute and what is chronic? I've included what is a subacute also. If you see the differences, how will be the onset? How will be the severity? What is the duration? What is the symptom progression and treatment approach? By keeping all this in the mind, you can come to the conclusion. If you see the example, acute pneumonia, recovery phase of the pneumonia, and chronic obstructive pulmonary disease. If you see this difference, especially when you see the chronic diabetes is something, it will be there for a long time, but it will not disturb you. When it will disturb, when you don't keep them in the control. Then what it says, what the background mind and background knowledge says to us, chronic is a condition. It will be traveling along with my life. Okay, the journey will be along with me. If I keep that in the control, it is a chronic. If I'm not able to keep that in the control, then it is going to become an acute or subacute. Okay, so that the management is very very important for the chronic condition. But if you see for acute and subacute, they will be in the fragile. Okay, they are very fragile where they may go up and down. The graph will be log phase or transition phase. Always it will be happening to the condition. So in that situation, so we should be able to understand the criteria, understand the scenario, understand the circumstance of the documentation, then come to final conclusion whether it's acute or chronic. Mostly this kind of situation we encounter, we used to see with the diagnostic coders, especially diagnostic radiology coders. Where if you see for surgery and ED, and they will not give much preference for this. But when it comes for the diagnostic radiology, and Bona, you are ED coder, right?
Yes, sir. Ready code.
Okay, I have one opening work from home, permanent work from home.
Yes,
Just
sir. I'm interested. Yes.
give the interview. Saw in channel, I dropped it today.
Okay, sir. Okay, sir. I'll see. I'll check it, sir.
Okay, let me just give me a minute. I will drop it now itself.
Okay, sir. Okay, sir.
After the thing, just try for the because now certification also not required there.
Okay, okay.
Okay, so you give a try. If you go
Okay,
through,
sir.
that will be good, right?
Okay, sir. Thanks.
Don't worry, we can continue the training. We will
Yes,
complete
sir.
the thing. But
Yes.
something, okay. Because I
Okay.
was thinking somebody from our training institute were looking for ED. That was keep on going in mind. It is permanent work from home. If you go
Okay, sir.
into that, we are lucky enough. You can sit in the home and work very nicely. Okay.
Yes, sir. That's
Just
good.
check. Okay, that Ferrado Healthcare is a nice place. Just check once.
Okay. Okay, sir. Thank you, sir.
Okay, so coming to our next point. Okay, so acute and chronic, that is a major difference. Okay, then next one is like, see, I've given some example. If you are the fresher, I would have told why that examples are required. Since you are an experienced person, it is not going to much work for you. Just know the definitions about that. You can analyze and take them. Okay. Then combination code, nothing like acute and chronic tonsillitis, both will exist, coexist together, where we'll be coding both acute and chronic condition. That is where I will be using the chronic condition in the certain places. Okay. So the pathophysiology, so the best coder, the good coder, how I see a small difference I used to tell to everybody. How you become an experienced coder or expertised in the coding. So experience in the coding and expertised in the coding is having small gap. Experience in the coding, somebody is going to teach you and something you are going to learn and something you're going to code. There is no documented proof, there is no analyzation, there is no R&D research, there is no self-learning, nothing will be there. How you become expertised when you put all this effort. Somebody is telling means where is the guidelines? In what basis this guidelines is followed? Because we have n number of guidelines. The CMS guidelines is there, commercial insurance guidelines are there, Medicare guidelines are there. Okay, AAPC guidelines is there, client specific guidelines is there. So when we come across all these things, how I'm going to analyze from the general concept, how strong I'm in the general concept. If you're good with the general concept, remaining all things you'll be able to pick up as much as possible. Okay, that is how you become expertised. So without doing this four step, you will just be experienced person where you will not, you will be stopping your growth, where you will be stopping your salary, everything will be stopped. See, this is something I used to call KPO, which means knowledge process outsourcing. We are not in the BPO. RCM is a BPO, but in RCM, coding is a KPO. Okay, knowledge process outsourcing. Every day, every week, every month, every year, we will be keep on flowing and updating ourselves from the anatomy, from the medical terms, from the pathophysiologists, and from the guidelines, APC guidelines, client specific guidelines, daily basis. Some half an hour if you're spending for that, we become expertised in that. Whatever the specialty, that is going to be very easy for us. Okay, so keep that kind of habit. That will give you a super growth. I'm not asking you to spend 1 hour, 2 hour, or 3 hours, just half an hour, not even half an
Yes.
hour. 50 minutes is sufficient. 5 minutes for anatomy, 5 minutes for the guidelines, 5 minutes for the general medical terms. That's enough on daily basis. Okay.
Yes, sir. Yes, sir. Okay.
Then next point is like combination code. Okay, combination code. So it is like two condition, it will be combined and coded as in one code. Okay, so some of the examples I provided, very vastly used ICD 9 code, which I was working during my time. So it is like 70322, say, and if you see the ICD 10 code L80 89.322. Okay, pressure ulcer lower back stage 2. Previously, we have to code separately. Now I can code it in a single code. Okay, pressure ulcer right lower back stage 2. So that is a combination code they're trying to do. It is like associating the other manifestation, okay, other complication, combining the other manifestation or other what is that other complication to form a one single code. Okay, so say for example, if you see patient with kidney stone and renal stone and hydronephrosis, we have the combination code. Emphysema with exacerbation, we have the combination code. Emphysema with bronchitis, we have combination code. So these are the condition interrelated where it gives, it will be depending on one another, the complication will be seen. So that is the reason we use the combination code, which will tell you two different conditions in one code. Okay, then C. coli. C. coli is nothing. It's a very self-explanatory one. To see on the C. coli, so a condition, okay, yes, condition after the treatment. So we think, okay, it is over. No more follow-up is required. But later cases, you will end up with what is it? Some kind of effort. Okay, the effects that is called late effect or C. coli. See some of example I provided. After the burn, the scar, what you get. After the deviation septum due to the nasal fracture, okay, after the fracture some deviations will be there, they treat the fracture but your nose will be deviated, so that is a type of condition. And next one is like infertility due to the tubal occlusion from the old tuberculosis. Because of the tuberculosis you may end up with some problem in your fertility also. Okay, that is what infertility. So likewise you will have the different set of conditions which will be like initially you will be treated, after a long time you will get that sequelae or late effect, where you need to code the condition simultaneously. You need to code what is a sequelae as well. Both need to be coded here. Okay, that is what sequelae or late effect. Next one is the impending and threatened condition. Okay, see this is something especially in the ICD book. Certain negative vocabularies we don't consider, like a suspect or something like something like suggestion. Okay, so this type of condition, like this type of what is it, prefix terms or this type of vocabularies along with any conditions we usually don't consider. Just give me a minute. I lost a power. Just let me connect the battery. Hope you are able to see the screen.
Yes, sir, I'm able to see the screen.
Okay. So impending or threatened condition. So this is a condition in the documentation. They need to provide impending or threatening. The term is very, very important. Okay. So without the term, these conditions we cannot be considered. Okay. If you see some of the list of conditions they're given: impending coronary syndrome, delirium tremens, or myocardial infarction. See, myocardial infarction, you get default. Sometimes they may tell it is an impending. So if a condition occurs, code confirmed diagnosis if only impending and threatening, then code if found in the index under those terms. Okay, so some conditions they may come, say for example impending renal impending nephrosis or impending calculus in the renal. If they telling like that, you have to come to the impending. Under the impending you have to check whether that condition is there. If it is not there, I cannot consider that, because certain conditions which is related to only the certain situation, based on that only they provided these two. See, threatening apart from the abortion, you will not be able to see in any other condition. You cannot see like threatening cancer or threatening a nephrosis or threatening cirrhosis or threatening pneumonia. You cannot see something like that. Okay, so where I use the term threatening, something lively happened inside your body, or something happening to lively conditions inside your body, that is a situation I use threatening. Apart from that, for others and all, you will not be able to use the threatening condition. So that is what they're trying to tell. If you see impending or threatening any condition, you have to come back and lead it in the book. If it is able to lead in the book only, you should be considering that. Otherwise, we shouldn't be considering that. Okay, that is the main purpose of impending and threatening condition. Next one is reporting same diagnosis code more than once. Okay, so what I'm trying to tell here is means, so certain conditions, okay, especially like if you see bilateral conditions, the codes will be almost similar. Okay, which is like if you have the bilateral code and well and good, usually you will have the code like right side, left side, bilateral, unspecified. Okay, this will be the majority. Sometimes you will go with the other specified also, especially when they're talking about organs or structures which are having the bilateral. 50% of the conditions, like 50% of the structures and body areas, you have the bilateral code. Few areas where I do not have the bilateral code, especially these ears, eyes, we do not have the bilateral code. So not for all the condition, very few condition. Okay, in that situation where I should be using the similar code, see almost similar. H 26.001 and 2, the 1 and 2 to just indicate the laterality. Okay, that is what I'm trying to tell here. Reporting the same diagnosis. Yes, it is the same diagnosis. Only the last character is going to get changed. Based on that, we are going to differentiate whether it is unilateral or bilateral. Okay, so that is a section says for the same diagnosis code more than once. Then comes the laterality. Again, laterality is nothing. So as I told, you may have the right, left, bilateral, unspecified. Based on the documentation, if it is right side, code right. If it is left side, code left side. If it is a bilateral code. That is what I'm trying to tell. That is the purpose of the laterality. Next, documentation by the clinician other than the parent, say patient provider. So what they're trying to tell here is like, so certain documentation. See, the key rule, the thumb rule of taking the diagnosis is like, whatever the physician is documented, only that need to be taken. The thumb rule is there is no assumption in the coding. What is the thumb rule for coding is, we should not be assuming ourselves. Unless or until the documentation is there, I cannot code. Okay, documentation is there means, which means physician should be taken different steps to do the diagnosis. Okay, he cannot just see by his naked eye and he can tell like cancer. Either he has to go for the laboratory test or he has to go for the imaging. Then he has to come to the conclusion, okay, so and so happened to the patient, so and so is there in the patient, normal, abnormal, okay, chronic, acute, something he need to document based on the documented proof which the analyzations he has done with, okay, diagnosis he has done with. Directly he cannot tell. But certain conditions, some exception conditions where that can be considered from the, like your patient provider means the patient who's been like the physician who is taking care of the patient for the long time, he can take some conditions, like document some condition without doing a diagnosis. So those are the conditions listed here, like body mass index, non-pressure ulcer, okay, pressure staging ulcer. Okay, so these are the some of the conditions or some of the scenarios where physician able to give directly without doing the diagnosis. Okay, then syndrome. What is syndrome? So there is a big difference. Sign we saw, symptom we saw. There's something called abnormality. There is a term something called a disease. There is a term something called disorder. There is a term something called syndrome. Now sign we know. Sign is a objective one which the physician or somebody able to see in their naked eyes. The symptom is a subjective one where the patient should be telling to the physician. Abnormality where diagnosis will be done by the physician, and abnormality is a type of condition. Okay, abnormality is a type of condition. See, under the condition only, abnormality will be there, disease will be there, disorder will be there, syndrome will be there. Now, when I say abnormality, that is something self-healing. You don't want to give additional treatment or medications for something. Okay, it will treat it by its own. It will not withstand for a long time. They may come and they may go. Especially if I wanted to tell good example, if you drink some hard water, immediately your liver will react and it will provide hepatomegaly, and that hepatomegaly in minutes that will disappear. Okay, there are enough data are the what is it? Medical data are provided. If you eat food or if you drink water or even cool drinks, especially when you drink Coca-Cola and all, like this soft drinks, your liver will enlarge immediately because the alkaline nature will change, and the alkaline nature will make the liver to enlarge. That becomes a hepatomegaly. But immediately after 1 or 2 hours, like maximum 1 or 2 hours, that will come for the normal. So that is a one kind of abnormality we can discuss about. Okay, then disease something it will be able to treatable. Okay, say for example cirrhosis, okay, that is treatable. And a kidney stone, that is treatable. Either I will do then a laparoscopy or something, like I will remove the stone, or a lithoscopy, something I will do, or I will take some medication which I can able to treat them. I cannot tell control, I can treat them. Okay, that is what called diseases. When it comes for the disorder, something like your entire physiology is different. It is turned into different way. Especially if you want to tell one good example, diabetes mellitus. Okay, we can take a diabetes mellitus as one example. It is changing your entire physiology. Since the insulin is not absorbed from your muscle or diabetes or type 1 diabetes, since the insulin is not produced by the pancreas, your entire physiology is going to get changed. Your glucose is not able to digest, and your glucose is not able to dissolve in your muscle. Okay, because of that, the glucose level is more in the blood. That becomes a diabetic patient. So that is a disorder where you can keep it in the control, but you cannot treat it. That is the disorder. Syndrome is a combination of few diseases or few symptoms or few disorder. Okay, it is not like one particular condition. That particular syndrome will lead you to some other problem. Say, for example, we'll take trisomy. Okay, trisomy is a syndrome which you will see in the, like, one X chromosome will be extra in your childbirth. Okay, during the, we can call it as a congenital anomaly also, we can tell. Okay, so where because of that, your normal physiological activity, normal growth activity, everything will be depleted. When it is depleting, that becomes a disorder. Okay, few can be kept in the control, few can be treated. Even you may get kidney failure also, you may get liver failure also because of that particular condition. So many syndromes are there. One good example which we see on daily basis, this one. Okay, so just a minute. Okay, sorry for that. Okay, so that is a big difference for the syndrome. So always remember, when you are looking for the syndromes, remember, when you're looking for the syndromes, you may encounter with the two codes. Okay, that is why they included one separate chapter as a syndrome instead of including disorder, disease. Why they wanted to include the syndrome means because all the syndromes will have additional codes. Code also, or manifestation code or etiology code, definitely you're going to get. That is what they're trying to indicate here. Then documentation of the complication care. Okay, so when it comes for the documentation of the complication care, so here, especially like previously, when it comes for the complication, we used to end up with the T series. Now, whatever the anatomical area, the complication is there, we will be using same anatomical area codes directly. Okay, so if you see complication care, what they're trying to tell you here is like, say if the patient, say for example, if patient has come for the fracture, he has fixed with the fracture. Okay, till the treatment, he will be in the S series only. Okay, for the fracture, initial encounter, or subsequent encounter, or non-union, or mal-union, whatever it is going to be the S series only. But when it becomes a complication, it is ending up with the M series. If it is a complication in this integumentary system, it ends with the L. If it is a complication in the gastrointestinal system, it ends with the K. So that is what I'm trying to tell this chapter. So whatever the condition is coming for, after some days, whatever the complication is going to get, okay, that complication need to be indicated in that particular chapters only. That is what documentation for the complication care. Then borderline diagnosis. Okay, this little interesting on borderline diagnosis. Like in outpatient, we will not be considering the borderline. Okay, we don't consider the borderline conditions, but certain conditions which will be indicated with the some measurements. Okay, some measurements or some unit, some quantity. Okay, that will decide that condition is present. Say for example, a patient is coming for abdominal pain, and in the documentation he is proved with the anemia. Okay, we'll think like that, he has proved with the anemia. Now the anemia is told like borderline anemia, whether I should consider or not. I cannot consider because there is no enough proof for the anemia. It is in the borderline. It is not going to be proved. It is not completely proved. Okay, that is the reason I will not be able to take. But diabetes, if it is borderline, means automatically that is going to increase, or it may go for decrease also. Anything may happen. Okay, it is like pre-existing diabetes or post-existing diabetes. It can become anything. Okay, so certain conditions, borderline can be considered. So especially these chronic conditions, if you see borderline, it is always related because it is developing. That is the reason they're telling borderline. Some acute condition, if they're talking about borderline, means I cannot consider that. If I have the documentation supporting with the units or measurements, okay, especially for liver cirrhosis and all, we have the stiffness study. Okay, even for the kidney, we have the GRF study. Okay, glomerular filtration rate. By keeping that, we can come for the conclusion. Even for the diabetes, by keeping the glucose level, we can able to come to the conclusion stating that borderline can be considered. Okay, then next is the same signs and symptom they're trying to talk here. Okay, so in the signs and symptom, if you see whatever we discussed previously, okay, so same subjective, objective only. Only thing is like when the conditions are proved, do not code signs and symptoms along with that. Okay, that is what they're trying to tell with this chapter. Next one is like coding for the healthcare encounter in hurricane aftermath. Okay, so in our country we see storm. Okay, thunderstorm, that is the terms we usually use. If you see the certain places in their country, okay, which is called hurricane. So storm is which one clockwise, that what is it, that wind will blow. Okay, you will see the clockwise wind blow in our country. Where it is in a hurricane, which happens in anti-clockwise, it is also kind of storm, but it happens in the anti-clock what is it, anti-clockwise, and it will create so much of damages. Okay, so based on that, okay, they have some set of codes like use of external cause morbidity code, sequencing of the external cause morbidity codes, and other external cause of morbidity codes. So what I'm trying to tell here is like, so when the patient is encountering the hurricane, okay, so the patient is coming into the hurricane scenario, we have to code whatever the condition is there. Followed by that condition, we need to address with that external cause. See, that is what we are following, but still they're addressing with the hurricane very deliberately here. Okay, so always first injury or whatever the problem happened because of the hurricane aftermath. That is what it is called, aftermath. Okay, then we need to code the hurricane code. Okay, so that is what I'm trying to tell with the use of external cause of the morbidity codes. So again, this is a small revision. So these are the set of guidelines we discussed so far. Okay, so I will do in brush up tomorrow also. So try to remember, if you're not able to understand anyway, it's just very straightforward. Only thing is like we need to keep in the mind and just we need to follow. And it is not like everything you are going to encounter in the exam. One or two conditions, like one or few cases, you will be able to encounter. Okay, so next section is like section C, chapter specific coding guidelines. Okay, so when it comes for the chapter specific, so I will be going one by one chapter. We do have 22 chapters. So let me give a highlight on each chapter so that you will be able to follow. See here, why we need this chapter. If you know the core, remaining everything is easy. Okay, so the core part of all the chapter is like, what is the sequencing of the ICD? Which chapter should be sequenced primary? In what scenario? Okay, in what scenario the condition should be coded as primary? That is what main. If you see chapter by chapter, that particular chapter is going to be the primary diagnosis. But when you see document wise, depending on the documentation, the chapters and the severity and the complexity, the sequencing will be differentiated. See, when it comes for CPT, based on the RVU value, we are able to document the CPT as the primary sequence or secondary sequence. When it comes for the ICD, based on the severity, based on the chapter guidelines, based on the documentation, you should be able to sequence the ICD. Okay, sequencing the ICD more than the chapter, we should be little. You should have little awareness on the conditions and pathophysiology of the condition. Okay, so when I say sepsis, at least you should know sepsis is an infection. It happens in the body, it happens in the system. It's an inflammatory infection happens in your system, and it leads to etc etc. It leads to organ failure, it leads to shock. Something you should be knowing. HIV is a viral infection. How severe it is. So there will be a list. If see, a patient is coming with a cancer, patient is having the HIV, and patient is having the fracture. Three different severe condition, which I need to code primary, which I should be coding primary. Now, depending on the condition, okay. So fracture is acute one, HIV is a long one. Even if you see like sepsis is also going to be the long one. Yes, sir. HIV and sepsis are severe. It doesn't mean I should be coding them because fracture is not severe. Fracture is something acute. So it happened now. So which I need to treat first? That only the documentation will be given in the primary. That is what physician will document as a primary here. Okay, so which is going to be mostly, it will be like so fracture will be coding primary because that need to be treated immediately. Okay, then you can ask me like HIV cannot be treated or sepsis. Yes, that also equally important, but without treating the fracture, which means without stopping the pain for him, how I'm going to take for other thing. Okay, so that kind of analysis, okay, that kind of thinking, okay, the background knowledge, anatomy knowledge, pathophysiology knowledge, something that will help you out to understand this whole chapter. Okay, you don't want to mug up anything, you don't want to you don't want to memorize anything, just try to understand the concept. Okay, so let me go by one so that you'll be able to understand how good it is going to work for you. Okay, HIV, yes, it is going to be severe always. In the HIV, we do have the symptomatic and the asymptomatic. Okay, symptomatic we have the separate code, asymptomatic we have the one set of code. Okay, so where depending on the circumstance, especially when the patient is coming, with the HIV related symptom, in that scenario, HIV should be the primary. When the patient is not coming, HIV related symptom means then HIV cannot be the primary one. Whatever the condition is coming for, that should be the primary. HIV test, that will be the primary ICD, because once proved, I will not go for the Z series. If it is not proved, means I will go for the screening. Okay, contact screening, asymptomatic infections. This all becomes the primary. So in HIV, patient coming with HIV related, code HIV as primary. If it is not coming with HIV related, don't code the HIV as a primary one. The second one is a sepsis and septicemia. Okay, in sepsis, we have the three set of sepsis. Okay, sepsis, septic shock, and severe sepsis. Okay, now if you see the sepsis, it is a systematic inflammation. If they're telling about which organism, we can go directly with the organism. Okay, if they're not talking about organism, A41.9 unspecified. When the patient is coming with the severe sepsis, we should code what type of sepsis it is. If the infection name is given, what type of organism. If it is not given, A41.9 again. Additionally, we need to use organ dysfunction, that is R65.20. Okay, 20 code we need to use. And along with that, we need to indicate what type of failure it is. When it comes for the septic shock, which is a combination of severe sepsis and cardiovascular collapse. In that scenario, I need to address with the R65.21 as a primary, followed by that what type of infection, followed by that I need to go for the what type of organ failure. If severe sepsis means that organism followed by, which means the infection followed by the organ failure. When it comes for the septic shock, I need to go with the severe sepsis, R series followed by A series, then followed by the whatever the organ failure. Okay, that is what the sepsis guideline stands for. Then next is like COVID-19.
So one small doubt, sir. Hello.
Yes, please go ahead.
Yeah, in sequencing, we will code first sepsis, no, sorry, first A41.9, or after that, we will code any dysfunction or else organ failure, no?
Yes, yes,
First
yes,
A41.9.
yes,
If it is dysfunction, R65.20. If it is failure, R65.21, right, sir?
yes, that is correct. Okay, so remember,
Okay.
infection will be the primary one. Okay,
Okay.
infection will be the primary. Infection is nothing. Usually, they will not give the information about what type of infection. Directly, they will be telling you the sepsis or severe sepsis or septic shock only they are going to tell. Whatever it is, the infection is going to be the primary first diagnosis. Then followed by that, we can go ahead with the severe sepsis code, which means like R series code. Then we can go ahead with the whatever the organ failure that can be followed. Okay, so see one sequencing I given here: infection first, then sepsis code. Never use sepsis as a principle if the reason for admission is different. That also you need to be little careful. One exception here. Okay, so that is what misconception I was talking about. People, if the patient is coming for fracture and sepsis, in that situation I don't use the sepsis as a primary. But
Yes, sir.
mostly 99.99% of the people, what they're doing, I see so many people when I do the audit, usually they'll go with the A series, telling
Okay.
that sepsis is severe. Yes, I agree, sepsis is severe. But what is the scenario here? He has not come to verify the sepsis. He is already a sepsis patient. They come for some other condition like cancer or for the fracture. That need to be coded primary. Then followed the infection we need to code. Infection sequencing we need to follow. Okay. That is a main and important thing here. Okay, the next one is a COVID-19 from 2025 we are using. So we have the combination code if they do for the along with the respiratory system like pneumonia. Okay, otherwise always this condition confirmed case should be the primary. Okay, so here it is like a light contrast to the sepsis. Okay, this is also infection, that is also infection, but here light contrast to the sepsis. Why? Because the patient is coming for other problem also. Our guideline says use the COVID as a primary diagnosis. There, if he's coming for the fracture, I should go with the fracture followed by the sepsis. But here, even he is going to be the fracture patient, they're asking us to quote U series as a primary. Why? Because that is something we need to quarantine the patient. Okay, even though he's going to be the fracture patient, I'm not going to ask him to stay in the normal place. I'm going to make him to sit separately. I'm going to make him to quarantine separately. Okay, so more than the treatment here, for me, quarantining is very, very important because it is a contagious. It may spread from one person to other person. So I'm looking into the treatment means then everybody will be get infected. Okay, so that is the logic behind that. So always the confirmed COVID will be the primary. If we have the combination code, yes, we have to code the combination code as well. Then sometime you may end up with the exposure suspected or post-COVID. Okay, this all like post-COVID, it will come in as a secondary diagnosis also. It's not like primary it is going to come. You will be ending up with the secondary diagnosis. Suspected and exposure, it will become the primary. Okay, so when it is proved, you should not use U07.1, but when it is coming for screening or suspecting or exposure, we should go with the Z20.822. So this scenario, you will not get a scenario like this. Fracture with a suspected exposure of COVID and all, you will not get. Either he has to come for this, otherwise he has to come for the treatment. Okay. So either confirmed case or he is going to be not confirmed case. Not confirmed case, default, I need to go with the Z20 series as a primary diagnosis. Then acute infection, chronic infection. Okay, code all documentation infections. You can most of the series first. Okay, infections always they're going to be the primary, but as I told, sepsis scenarios or HIV scenarios, certain places that may get varied because of the circumstance. Okay, but COVID, it is well and clear. We are going to use a confirmed condition as the primary diagnosis. Okay, then chronic infections. Yes, chronic infection. It is not like always it is going to come primary if the chronic condition is in the exacerbation level, severe exacerbation, acute exacerbation. See, especially more than the severe exacerbation, we can tell like acute exacerbation, which means present. Presently, the problem, the chronic condition is developing. Exacerbation means it is becoming adverse. It is growing. It is progressing. So in that scenario, I need to give the treatment for that, preference treatment for that. That will become the primary code. Then one more infection, that is methicillin resistant staphylococcus aureus. Here also confirmed case, code that as a primary. Suspected case, when he is coming for the suspect case, okay, code clinical signs and symptom. Do not assume MRS without a confirmation. Okay, so always if there is a code, separate suspected code, Z series code is there. I cannot code that as a primary, but MRS, I need to code the signs and symptom, followed by that only. I need to go for the suspected condition, okay, which means suspected codes. Then MRS colonization, okay, which is like Z86.14, personal history for the MRS infection. Even this is something like we can go for the secondary code also because it's the history. Some situations they may encounter to verify what is the status of the MRSA. In that situation, I need to indicate a Z86 as a primary. Otherwise, if the patient is coming with some other problem, some other condition, that can be coded as secondary. But if it is confirmed, no other go, I need to go with the A41.2. Okay. Otherwise, I may go end up with the cause of the condition or the cause of the infection, which is like B95.62. Mona, just a moment, Mona. I will come back. Okay.
Okay, sir. Okay, sir.
Sorry, Bono, we'll continue.
Yes.
Okay, so next one is like we'll be entering into the chapter 2. Okay, so chapter 2, it will be talking about the
Mm,
new
yes.
class. Okay, so in the first one thing I forgot to tell you. In the first thing, we will be encountering the infection codes from A00 to B99. Okay, A00, which will be like direct infection cause codes, will be coding. Okay, wherein when it comes for the B series, you will get the infection. What is the cause for that infection? Also, you'll be able to see in the B series codes. Okay, so both the places, yes, one set of codes, it will give you the conditions like infections related to the bacteria. One set of codes, it will give the conditions related to the virus. Okay, but again, this both, especially when it comes for the virus related and all, you need to have the what is the cause for that. That is the reason if you see HIV and all, it will comes under the B series. Okay, sepsis and all, we do not know the cause, that viral infections or the bacterial infection, we don't know what is the cause for that. So they categorize like this: bacteria is all they kept into the A, virus all kept into the B, because virus will have the what is the causative agents as well. Okay, then coming to the next one, next chapter, neoplasm, which will be C series and D, C002 to D49. Here, just a small input on what is neoplasm, what is tumor, all these things. So because always we have a what is it, that the term called cancer. Generally, we are speaking everywhere. Okay, so cancer is something, it indicates all type of cancer, which means like all type of abnormal growth. So we do have different type of abnormal growth, starting from the primary, secondary, benign, in situ, unspecified, uncertain. These all are different. Okay, so what is tumor and what is cancer? What is malignant and what is benign? Okay, so if you see, we can categorize in two ways: malignant and non-malignant. What is malignant? Malignant will be able to spread from one place to other place, and it is a painful. Malignant is a able to spread from one place to other place. It is a painful. One more important is like it is fastly or uncontrolled growth will be there. Rapid growth or uncontrolled growth will be there. That is a malignant. Okay. What is non-malignant? Non-malignant means which will not have the rapid growth, which means which will not grow very faster, and you can be able to see the cells are well differentiated, which means well grown cells. Okay, completely it has been developed cells. Okay, divided cells, and it will not be able to spread. Okay, whichever the malignants, okay, whichever the non-malignant, okay, non-malignant is not able to spread, they brought them into the tumor. Okay, they brought them into the, so neoplasm means new cell development. Okay, we can tell new cell development. In other terms, we call it as a tumor. Now, the tumor is a term, generally they are used now, mostly they are using condition like growth which is not spreading from one place to other place. See, here I have given you the tumor is again segregated into benign and malignant, but the tumor is a term is always used for most of the cases. It is used for the malignant conditions, which are, sorry, the non-malignant growth, which is not spreading from one place to other place. See, if you see this carcinoma in situ or benign, okay, this all comes unspecified behavior. This all comes under the tumor. Okay, if you read in the book also, under the tumor, you will be able to see all the D-related codes only. You will not be able to see C-related code. Okay, C all malignant codes. So in the malignant, we have two type of malignants. One is primary site and another is a secondary site. Okay, or primary malignant or secondary malignant. Primary malignant is the place where the cancer is developed and it is growing. It is not only growing, it is spreading also. When it is spreading from one place to other place, the area where it is going to reach, that area is called secondary malignant. Okay, otherwise we can call it as metastasis. Say for example, I have the brain cancer that is spreading to the liver cancer is called as metastasis. Otherwise we can use one more term, metastatic disease. Very importantly, metastatic disease. Metastatic means able to spread. Met means spread. Metastasis, spreaded. Metastatic, able to spread. Okay. Lesion also they may use the term. Metastatic lesion means the lesion which is able to spread. Metastatic mass, metastatic cyst. Okay. It is not only metastatic malignant, so it is not only metastatic disease. Other conditions also they may use with that particular term. Okay. So primary, secondary, malignant, able to spread. Whereas benign, carcinoma in situ, unspecified, uncertain behaviors, they all comes under tumor. Okay, here I given under the tumor both are given. Yes, Some cases they're talking like that, but for us, always tumor will come under the D series. All the D series will be benign, carcinoma in situ, uncertain behavior, unspecified behavior. Okay, there's a major difference. Now, primary versus secondary. When primary is there, secondary is there, always code primary followed by the secondary. When the primary is there, secondary is given the treatment, then code that secondary as the primary one and code the primary as the secondary DX. Okay, you able to follow me? You able to understand what I'm trying to tell here?
Yes, sir. Yes, sir.
Okay, so majorly, just a moment. Hello. Okay, sorry for that. Okay, so keep that very simply, keep it in the mind because don't complicate it. The core product only we need to know. Okay, so I will give you like a layman terms. I will tell you. Try to keep it in the mind, associate and keep it in the mind. Okay, primary, secondary, code primary followed by the secondary. Primary, secondary. Now based on the treatment. If the treatment is provided for the primary, code primary as usual and followed by secondary. If the treatment is provided for the secondary, code the secondary as the primary DX, then followed by the primary. You are clear in this?
Yes,
You're
sir.
clear?
Yes, sir.
Okay.
Yes.
Now, one more will be there. Okay, one more. The treatment which will be provided with the chemotherapy or with the radiation therapy. In that situation, you have to code the Z series primary for what is providing the treatment. Primary cancer is providing, a secondary cancer is providing. If it's providing for the primary cancer, Z followed by Z5150 series, it will come. Z followed by primary, then secondary. If it's treating for the secondary cancer, Z followed by secondary cancer followed by primary cancer. Now, patient is coming with the history of cancer and metastasis of cancer. Okay, patient is coming for the history of the cancer and metastasis of the cancer. Now, metastasis will go as a primary and history will become a secondary. Okay, that will become the secondary code. Okay, keep that in the mind. Then
Yes, sir.
history like that series always goes for the secondary. Keep that in the mind. Then apart from that, current status treatment history. Okay, if is no malignancy means history means that will come secondary. Then history versus current malignancy, whatever I told, same we can go. Okay, which means when the patient is coming for the history of the cancer means I cannot use the current cancer code. That is what they're trying to tell. Okay, then follow up or surveillance it is there means I need to use a what is it, follow up code or treatment code, whatever that is, that should be primary. Followed by that only I need to code whatever the cancer it is. It may be history of the cancer or current cancer. I need to go to the surveillance, then followed by the other codes. Okay, in down, the treatment I was talking about, Z51 series, that will become the primary, followed by the primary treated means primary, secondary treated means it will become the secondary DX. Okay, depending on the what malignant is treated, that will become the next to Z51 series. Okay, principal diagnosis. I will use the term principal diagnosis. That is what we use in the IPDRG also. Okay, principal diagnosis, primary diagnosis. Okay, what is the difference between the principal diagnosis and primary diagnosis? Any idea?
Oh, no, sir.
Okay, so principal diagnosis means, okay, the condition which is a reason for the procedure. Okay, that will be the principal diagnosis. Primary diagnosis means the condition which is proved, that will become the primary condition. Oh my God. Okay, Buna,
Huh, sir. Tell me, sir.
I will stop the class here. Okay,
Okay, sir. No problem, sir.
I think almost for 1 hour, no power. My battery got drained very fast.
Okay, sir. Okay, sir.
Almost I'm done with the battery. I think. Okay, it's only 6% is there. Okay, I
Okay,
will
sir. No problem. We'll
we'll
start.
continue on Monday. Tomorrow we will not have the class. We can
Okay, sir.
continue on Monday. I will provide you this is that recording as well. Okay.
Yes, yes, sir. Yes, sir.
Now itself I will stop. Yesterday I forgot to stop it.
Okay, sir. Thank you, sir.